starting now. And then I'm going to go ahead and screen share. So this is up on the screen too. And then your names won't show on the whole screen. Okay. There we go. Okay. Do y'all see my PowerPoint?
Yes, ma'am.
Okay. I wanted to begin by saying that the viewing the weekly webinar is not optional. It's one of the requirements of the course, and whether you tune in with us on Tuesday night or whether you watch later is your choice. There's no requirement to watch on Tuesday, but there is a requirement to watch at some point, because a lot of what I talk about on Tuesday is essential for your learning. And so it's your choice when you watch, but you do need to watch. I do get a count of how many people have viewed the webinar, and that's pretty low at the present. And that may account for some of the lower grades we've had on our tests. We've had a lot of really high grades, but we've had a number of, we've had a few really low grades, and a few folks who seem to have some misunderstanding of some concepts that we have covered in the webinar. And I would imagine that if you're watching the webinar, listening to some of the lecture via the webinar, you'd pick up on some of those nuances that perhaps you're not expressing in the discussion board or in your reflections or in your answers on the tests. So make sure that you do watch the webinar in its entirety. They're not that long, an hour of your time, but that's what you would do if you were on campus and attending the class face-to-face. You'd come to class on Tuesday. If it were a face-to-face class that we're meeting twice a week, you'd come Tuesdays and Thursdays for an hour and 15 minutes, or on Tuesdays only for like a two plus hours. And so devote as much time to your study of the course on the online format as you would if you were face-to-face on campus, having to come and sit in class. And know that the requirements are different, but the time requirement should be, I would say, at least equal to what you would spend if you were attending the campus class face-to-face. So I know it's not as fun as a face-to-face class where you have your classmates sitting, at the table with you or across the aisle from you in another desk. But it is essential to your learning to be able to get some of the information from your professor and from reading your text, those kind of things. So make sure you're putting the time in. All right, let's go ahead and dive in tonight. We've got two different disability categories we're going to cover, all under Chapter 10. And Chapter 10 deals with physical and health disabilities. So the two of the IDEA categories that we're going to cover are orthopedic impairment and the category that we call other health impairment. And we're going to dig into that a little bit deeper. I know that on the discussion board for that first week or two, after we did the little quiz about the different disability categories, I think some people, have an idea of what this other health impairment category is. And it's an area where we have a whole lot of misunderstanding. So maybe we'll get a little bit of clarity with that tonight in our discussion. So we're going to start off with orthopedic impairment, and this is the legal definition of both orthopedic impairment and other health impairment. So we'll review those quickly and then get on into some of the meat. We're also going to cover, I think it's traumatic brain injury. So we'll look at these three. I think traumatic brain injury is on the next screen. So orthopedic impairment, that's something that's caused by a congenital anomaly, such as a club foot or the absence of one of the members of the body as far as the limbs are concerned. So your hand, your foot, your arm, leg, something like that, that's taken by disease such as poliomyelitis or bone tuberculosis, and by other causes such as cerebral palsy, amputations and fractures or burns that cause contractures. So that's an orthopedic impairment, something that impairs generally mobility. The person can't walk or can't perform movements that they need with their hands or arms. Other health impairment. Now, this is a really broad category. And I told you all at the beginning of the year that it includes things like attention deficit disorder, hyperactivity disorder. It includes asthma. It includes any kind of health defect that impairs the child in their learning at school. So here's a list and a kind of a definition. It says a disorder resulting in limited strength, vitality or alertness, including a heightened alertness to environmental stimuli, which results in limited alertness with respect to the educational environment that is due to chronic or acute health problems, such as asthma, attention deficit disorder, or attention deficit hyperactivity disorder, diabetes, epilepsy, a heart condition, hemophilia, which is a blood disorder, lead poisoning, leukemia, which is a cancer, nephritis, which is a kidney disorder, I believe, rheumatic fever, Tourette syndrome, and sickle cell anemia. Now that's just a for instance list. It's not an exhaustive list of everything that could possibly go under this heading of other health impairment, but it's a list of possible health conditions that would impede a student with, and you saw that key word up there in the top of the definition. It had to do with alertness, strength, vitality, those kind of things that impact somebody's health to such a degree that they're going to have difficulty performing in school. And then the third one under this this heading in today's chapter, the category that we would find under IDEA is traumatic brain injury. And the definition for that is an acquired injury to the brain caused by an external force, resulting in total or partial functional disability or psychosocial impairment, or both, that adversely affects a child's educational performance. Now, the term applies to open or closed head injuries, resulting in impairments in one or more areas such as cognition, language, memory, attention, reasoning, abstract thinking, judgment, problem solving, sensory, perceptual, and motor abilities, psychosocial behavior, physical functions, information processing, and speech. So a whole lot of things that can be impacted by a traumatic brain injury. The term does not apply to brain injuries that are congenital. That means things that happen before birth, or degenerative. Those are brain disorders that cause the brain to slowly degenerate or lose its functioning. So some sort of a brain disease that causes the brain to slowly stop its functioning, or to brain injury induced by birth trauma. So if the doctor uses forceps during the birth and damages the child's brain, that would not count as a traumatic brain injury. And then here's a special note. Each condition requires an adverse effect on educational performance. So all of the things that we've looked at in these three categories, these subcategories here that we're going to look at today, would have to impede the child's educational performance to such a degree that it's going to have that adverse reaction that needs specialized instruction. So how prevalent are these three categories? Well, remember that we're in the section of our textbook now, in the section of our study this semester, that we call low incidence disabilities. The first few chapters that we studied were our high incidence disabilities: learning disability, an intellectual disability, emotional disturbance, speech impairments. Those are our high incidence disabilities. Everything that fell into into unit 1 under our first test, our second test, that first unit of disability studies were all high incidence disabilities. And now this next section that we're going to study are our low incidence. And so we studied auditory impairments and visual impairments last week. Those are low incidence disabilities. And this next set that we're studying this week are also low incidence disabilities. That means they're not very frequently occurring. So we have a 0.10% of our school-age children that fall into the orthopedic impairment category, a 0.85% that fall into the other health impairments category. And they're called other health impairments because you can see it's kind of a catch-all. We have a lot of different things that are considered health impairments that fall into that category. And then a 0.04% of our school-age children that fall into the traumatic brain injury category. And you add all those together for a prevalence of 0.99% of our school-age children fall into these three categories together. So we're talking less than 1% of our school-age population fall into one of these three categories of physical and health disabilities. So not a whole lot of the kids in school. And it seems like there's a lot of kids who have that ADHD, ADD diagnosis. But remember, you can have that diagnosis and not have a special education label. So not everybody who has ADD or ADHD rises to the level of needing specialized instruction. So you've got kids in school who have ADD or ADHD, as I'm sure probably some of the students in this class did, or maybe your siblings did. But unless they received special education for that, they would not fall into this category. The need would have to be high enough that it was impacting their education so much that they needed specialized instruction or special accommodations or a special setting for that impairment. So some kids who have ADD or ADHD fall under this category, and others fall under the category of Section 504, where they don't need specialized instruction, they just need some accommodations. And that's our Section 504 set of kids. And then we have kids that have more serious educational needs who have that disability, and they fall under the special education umbrella. And so when you get out into schools, that's what you'll find. So let's talk a little bit about orthopedic impairments. We're just going to hit a few that that will fall under this. Now, let me say this first. If you have a broken leg and you need to go on crutches for a while, that would not put you into special education because of that orthopedic impairment, because it's short term. You're not having a prolonged need. You may need some accommodations for that broken leg for a while. Maybe you've had surgery and you need to be on one of those scooters for a while. Maybe you've got the lower part of your leg in a brace or a cast or something. Maybe you even need a wheelchair for the time being. But unless that is prolonged for a substantial period of time, and you need more than just some accommodations to get around the school, you need specialized instruction, you need a lot of other things to support you in your education that would not rise to the level of adversely affecting your educational performance. And so when the need crosses over from just accommodations to more than that, that's when special education steps in. And it would need to be over a prolonged period of time. So just a broken bone that heals, or maybe even the results of, of complicated surgery. Uh, that's not usually a special education issue. Now, disease that goes on for a prolonged period of time, a student who has bone cancer or something like that, that they're being treated for a long period of time, and perhaps other factors feed in, um, and they're out of school for long periods of time, and they're losing instructional time, and perhaps other issues are affecting their performance at school, then we might be looking at special education for that impairment. But it might be more of a, maybe even an orthopedic, more of a other health impairment in that situation because of the bone cancer rather than the orthopedic impact that's happening there. So each of those, of course, are taken on a case-by-case basis. So let's talk a little bit about cerebral palsy, which is one of the causes for orthopedic impairments. Usually it's a paralysis that occurs. But the causation for cerebral palsy is here on your screen right now. It is damage to the brain before, during, or shortly after birth, probably related to prematurity and intrauterine development. So oftentimes the doctor can tell an expectant mother that cerebral palsy is happening in utero. Sometimes sometimes not. It's not known until after birth. But with all of the sonograms that take place now and other kinds of tests with expectant mothers, oftentimes, usually, that's something that's known before birth rather than after birth these days. There are 4 different types of CP, and you see that listed on your screen. We have spastic, athetoid, ataxia, and mixed. And you see the definitions of those. Spastic CP is where the individual has very stiff movements. Athetoid are involuntary movements. Ataxia impacts balance and coordination. And then mixed is a combination of some or all of these types of CP. And then we have areas of the body that are affected. And then we differentiate the type of CP that the individual has based upon those first 4, and then the areas of the body that are affected as well. So monoplegia impacts one limb. Double hemiplegia impacts one side of the body. So perhaps the right arm and right leg are impacted because of the damage that's occurred to the hemisphere of the brain. Diplegia is symmetrical parts of the body. Paraplegia means 2 limbs are impacted, and that would probably be legs or arms. Triplegia is 3 limbs are impacted, and quadriplegia, as you probably know, is when 4 limbs, or all 4 limbs, are impacted. Other associated conditions that go along with CP, oftentimes, I won't say usually, but oftentimes there are seizures involved. Many times there are vision problems. Sometimes there's a hearing loss. Sometimes there are eating, feeding, and speaking problems, issues with communication because of the structure of the mouth and the control of the tongue, the lips, etc. And then about half to a third of the individuals with CP have intellectual disabilities as well. Now, sometimes we assume that because of the way a person moves or the way they speak or cannot move or speak, that they have an intellectual disability. And of course, that's very untrue. But sometimes we make that assumption based upon the way a person moves or communicates. But we've got to make sure and understand that we can't make that assumption based upon outward appearances. We've got to get to know a person and find out more about their their intellectual functioning before we make any assumptions about that. So sometimes we've got to have those conversations with teachers about where a child actually is functioning on the intellectual spectrum and on the academic spectrum, because sometimes we tend to make those assumptions based upon the way a child moves or the way the child speaks. Spina bifida. Spina bifida has is a congenital disorder that results when the bones around the spinal cord do not grow together and close before birth. And there are three types. There's the most common type, which oftentimes individuals don't even know until later in their lives because it's so minor, and it's called spina bifida occulta. And there's maybe just a little bit of space that doesn't close up in the spine before birth. And like I say, oftentimes people don't even realize that. There's estimates that could be anywhere from a fourth to a tenth of the population to a fourth of the population that doesn't have that full closure of the spine at birth. And usually there are no problems. The next type is meningocele, and that is the type of spina bifida that is reparable. Surgery can be done. It's more serious than the spina bifida occulta. It's less common, but it is still reparable with surgical procedures. Then the most serious is the last one of those top three bullets, and it's meningocele. Again, the most severe when the spinal cord actually protrudes through the child's back at birth so that the nerves are exposed. And that also requires surgery, but sometimes individuals have a difficult or impossible time overcoming some of the obstacles that come up from spina bifida of this severity. Sometimes it causes paralysis, loss of bowel or bladder control, difficulty breathing and swallowing. Sometimes it causes seizures. And 70 to 90% of individuals with spina bifida also have what we call hydrocephaly, and that is water on the brain or fluid on the brain. And so that's a complicating factor. I know a young woman at my church who just recently passed away. She was in her 20s, and she's had spina bifida obviously her whole life, but she was paralyzed. She had the type, let's see, we were just looking at here. Let's see. Nope. She had the most severe type, and she had paralysis from the waist down. But she had some subsequent difficulties that recently have caused her more difficulty with breathing and swallowing, and more of the accumulation of fluid on the brain. And she ended up passing away just a few weeks ago after some repeated surgical procedures didn't seem to have a positive outcome. Okay, the next one is muscular dystrophy. The cause of muscular dystrophy is primarily genetic. It's a disorder characterized by a general progressive weakening of the muscles. It is a degenerative disorder that results in fatality. It's a very, very sad disease. The primary, most prevalent and most common type is Duchenne muscular dystrophy. You may have heard of that one. You know, for years and years, there was the Jerry Lewis telethon that occurred every Labor Day. You may have heard of that when you were younger. Jerry Lewis I believe he's passed away now. If not, he's not able to do that telethon anymore. I'm not sure if they still have that telethon, but they still raise a lot of money for muscular dystrophy. And the onset for that disease occurs during preschool years. And like I say, it's degenerative, and it is a fatal disorder. It begins with initial weakening in the lower leg area, and then individuals usually need to use a wheelchair by the age of about 10. They're usually on a respirator by age 20, and death typically occurs in the early 20s. So it's a very, very sad progressive disorder. Under the category then of other health impairments, we'll just touch on a few, and one of those is epilepsy. The cause of epilepsy is an electrical dysfunction in the brain resulting from disease, injury, or developmental abnormalities. It results in problems with consciousness, movement, and or sensations. There are two types of onset. There's what we call generalized, and that affects large areas simultaneously in both hemispheres of the brain. And then there's partial, but there are two kinds of generalized. There's generalized tonic-clonic, and there's absence seizures. Now, the generalized tonic-clonic are what we used to call grand mal seizures, and those are the ones that you see described on television, where somebody falls out and has the shaking, and they talk about foaming at the mouth, and put something in their mouth to keep them from biting their tongue. That's the real stereotypical kind of seizure. The second one is actually much more common, the absence seizure, and that's what we call a petit mal seizure, what we used to call a petit mal seizure, and now we call it an absence seizure. This is where an individual just kind of looks like they're staring into space. This may be happening in your classroom and you never even realize it. You think the child is just daydreaming or something, and they may actually be having a seizure. And this is what teachers oftentimes miss, because it's so nondescript. Then we have partial seizures. Those are the two types of generalized seizures. Then we have partial seizures. They start in one specific area of the brain and may or may not spread. We have simple partial seizures, and then we have complex partial seizures. And we call that, the second one we used to call psychomotor. Another health impairment that we see often in schools is asthma. Now, you might say, well, now how does asthma impede a student in their learning? Well, it can very greatly impact students in physical education activities. Kids oftentimes need an inhaler, have it handy. Maybe they need to have access to the nurse's office. Now, all of those kind of things I think could be handled through a 504 set of accommodations. But if they're frequently absent because of this kind of thing, or they need something more than just a trip to the nurse's office, this might rise to the level of needing a special education label. It is a respiratory condition that results in breathing difficulties. The cause is inflammation of the airways or by tightening of the muscles around the airways. Typically results from exposure to various environmental conditions. Characteristics are wheezing, coughing, tightness in the chest, treated with medications and inhalers. Cystic fibrosis is another one. This is also a degenerative disorder caused by a recessive gene in which mucus, which is usually watery and moistens certain body organs, becomes thick and sticky. Then the lining of the lungs actually stick together when the individual tries to breathe. Like I said, it is degenerative with no known cure. It's caused when both parents are carriers of the defective gene, and then they have children who are, if the two parents both have the are both carriers of the defective gene, then there's a, certainly a high likelihood that the child will have it. I think maybe even the child is certain to have it. I'm not certain about that. I shouldn't say that because I'm not certain about the genetics of that. If the child will or will not, they may have the high probability of it. I'm just not sure about the genetics of that. And then the symptoms are persistent coughing, frequent episodes of pneumonia, dehydration, a large appetite with no subsequent weight gain. They're usually very thin, and life expectancy is upper 20s to, I think it has recently been raised to about 35 years of age. My stepdaughters had an uncle who had cystic fibrosis and died, I think, at the age of 27 a few years ago. And it is a terminal disease as well, and very, very sad when a young person's life ends like this. And this is one of those where when you have that disorder, that you're going to die young, and that's a really tragic thing for a family. Diabetes is our next one. A disorder in which the body does not produce or effectively use insulin. And we've got two types. The first one, onset is during childhood, type 1 diabetes, and type 2 emerges during adulthood. The causation is often a genetic predisposition. And we also have dietary factors. Usually the genetic predisposition is type 1 and the dietary factors occurs with type 2. And the symptoms are hyperglycemia, which is high blood sugar, increased hunger, thirst, urination, blurred vision, dry mouth, dry, itchy skin, and hypoglycemia, which is low blood sugar, increased hunger, perspiration, nervousness, sleepiness, and dizziness. And most of us know somebody who's got diabetes. It can always worsen with age. I recently lost a friend with diabetes after she had both legs amputated at the knee because of circulatory issues, and then passed away in her 50s. The next one is the acquired immune deficiency syndrome, which is AIDS, which we've all heard of, caused by the human immunodeficiency virus, or HIV, which is transmitted sexually through blood or from mother to unborn child. The symptoms are swelling of the lymph nodes, enlargement of the liver and spleen, a predisposition to viral and bacterial infections. Other problems may include cognitive deficits, motor functioning problems, speech, language deficits, and problems with memory and attention. There is susceptibility to infections, and frequently the child becomes chronically ill. It's important to note that now I'm of the generation that went through the AIDS scare back in the 80s and early 90s when AIDS really first became known in this country, and everybody was fearful of AIDS. It seems to have kind of been brought under control in the last number of years, but we were all really, really scared of AIDS for a time there, and it was all people could talk about. And I had several friends who died of sexually transmitted AIDS back in the late 80s. But I had a student in a previous district where I was the director of special education, a student who had AIDS. No, that's not correct. He was HIV positive. He was HIV positive because of his mom, who had been a drug addict, a drug user and a drug addict, and had passed the HIV to him through the birth process. And when I took my job in the district, I was told about that student, but then I was also told that that the teachers were unaware of his condition. And I was a little boggled by that, because I thought, well, no, certainly they're entitled to know. This student was very disabled. He was in a wheelchair. He was severely cognitively disabled. He was in a wheelchair. He did not have oral language, didn't speak. He had to be, he was in middle school at the time. He had to be fed by our teaching assistants in the room. They fed him with a spoon, and he had to be diaper changed every day. So he, he didn't have bowel or bladder function. He was a young man, in his early teen years, early to mid teen years. So he was about maybe 14, 15 at our middle school. And totally dependent on other people to feed and toilet him. So I was concerned about body fluids, and I was told that nobody that worked with him had a right to know about his condition. And I said, well, that just doesn't seem fair. But then I was told, well, it's perfectly fair, because his right to privacy is greater than their right to know. And what we've got to be doing at all times is practicing all those universal safety precautions. And if we're doing that with every child, then there's no need to be concerned about passing along any kind of virus like this through body fluids, such as, his saliva that might be transmitted during the feeding process, or his urine or his feces that might be touched during the diapering process. And I struggled with that some, but ultimately realized that that's true. We just need to assume as teachers that everybody has a communicable disease. And then we need to practice those universal precautions with everybody. And you'll see that when you get into the teaching field, or whatever tangential field you may be going into, if you're going into child care of some sort, or some sort of a hospital setting for your work, you'll get some kind of training at the beginning of the year about those universal health precautions. And you need to take that training seriously, because you never know about the condition of the students that you're working with. So even if you're a kindergarten teacher, you don't want to reach down with, your bare hand and start wiping somebody's snotty nose, or even somebody's tears. You want to use precautions before you touch a skin, the blood on a skinned knee, or any body fluid of any other person, because you never know about that person's health history or anything else. So use those precautions regardless of where you are and who you're working with. The next one is traumatic brain injury, and this is an acquired head injury caused by an external force. Major causes include lots of different things, just about anything you can think of that's an external force. So a car accident, a fall, a violent injury, a sports injury. Those are the things that come to mind immediately. And I have worked with students through the years who have had all of those and some other things. It includes open and closed head injuries. So it could be, the head that's split open when the child hits the dashboard of the car, or the windshield of the car in the car accident. It could be the closed head injury when the student falls off of the ladder or falls off of the roof when they're being being silly with their friends. It could be when they stay, when they are unconscious after they hit the bottom of the swimming pool and stay under the water too long, and they have a brain injury due to a lack of oxygen to the brain because they've been under the water in the pool too long. I had a student who had a gunshot wound to the head. I had a student who attempted to hang himself and had a lack of oxygen to the brain. His father was a paramedic, though, and went to the barn and found where he was hanging before he was dead, and rescued him and performed CPR and brought him back. And he became a student with a traumatic brain injury in his senior year. He had been a standout student on the honor roll until the second semester of his senior year, and he had broken up with his girlfriend over Christmas and was quite despondent, and went out to the family barn and attempted suicide, and became a student with a traumatic brain injury in special ed for the rest of his school career after Christmas of his senior year. I had a student who was in a hunting accident. His father accidentally shot him. I've seen students with all kinds of sport injuries, concussions that were really, really bad. Things like that were sport related. And so all kinds of things can fall into this category. It includes accidental and intentionally inflicted injuries. I've had several kids who were victims of the shaken baby syndrome. The ones I know of off the top of my head were babysitters. I can think of two of those that were shaken baby by babysitters. One was one that the parents did pursue charges against the person, and they did go to jail. Another one, the person fled back to their home country and did not receive any kind of repercussions for their actions when they fled the U.S. The characteristics of the TBI are dependent on the type and the location of the injury. What part of the brain is impacted? Is it the frontal lobe? Is it the parietal or temporal or occipital lobe? What part of the brain has the damage? The severity of the injury, is it mild, moderate, severe, profound? The age of the individual when the traumatic event occurs. Depending upon what part of the brain occurs, I had a student who had a shaken baby, and then had injury to her arm as a result, because the part of the brain that controlled the arm itself wasn't damaged, but the part of the brain that controlled the arm was damaged. And so she couldn't write later on with her right hand because she held that arm up close to her with her hand in a permanent little fisted position, because the part of the brain that controls that arm was damaged. And that happened when she was very young, prior to the age of 1. Changes may be observed in the child's physical, cognitive, behavioral, and/or academic functioning following a TBI. Certain parts of the brain have the ability to regenerate. And so some kids, depending upon their age and the part of the brain, we may see brain renewal. I worked with a student who was in the 5th grade when she was in a terrible car accident. She basically lost most of the education she had had up to that point. But when she got back into school after months of hospitalization and months of therapy, her brain began to regenerate. And she began to recall things that she had learned, and things began to come back to her. So that can happen. In other cases, it doesn't. So the brain is a very finicky organ. So what do we do when we see physical health disabilities? What are the schools responsible for? Well, first we make identification, and that happens with our reliance on medical personnel. They are involved in the decision-making of all eligibility determinations of these subgroups. So we've got to have the medical professional telling us what's going on. They give us identification. They tell us what the particular disorder is, what the prognosis is, and what we as school personnel need to be doing about that specifically. Most of these students are going to need some sort of therapies, whether it's physical therapy, orthopedic kinds of therapy with occupational therapists. They may need other more specific kinds of things that happen in a clinical setting away from the school. There are a wide array of disability types and needs among these groups. They do have to have access to the general education curriculum, but it's going to vary greatly according to the type of disability that the student has and what their needs are going to be. So we look at each of these in a very specific, individualized way. Special health care issues are paramount. They come first. And so if a child has a heart condition or has asthma or has some of these other kinds of health conditions, we're going to look at all of the medical side of things first and work with our nurse's office and work with the students' healthcare professionals to come up with a plan, a health plan that works in the school setting. We always want accessible classrooms and adaptive equipment and instructional technology that works for that student. And then we're going to work with those professionals that can tell us to what degree the student is functioning so that they can work in our classrooms most effectively. Like I said, a number of these students may not have anything wrong intellectually. The issues may be completely physical in nature, completely health in nature. And so that's not going to impact the student, intellectually or academically. We're just going to have to work around those physical and health barriers so that the student can access the general education classroom and curriculum most effectively. So getting them there, getting them in a spot where they can learn, getting them the materials they need is going to be paramount. Now, with some students who do have intellectual factors working against them, where their intellect and their academics are impeded a lot, then that's where we're going to work real closely with the special education teacher to see about developing a program and a plan that's going to support them most effectively in general education. We got any questions?
No, ma'am.
Okay, folks, that's it for tonight. That's chapter 10, our physical and health disabilities. All righty.
Thank you.
You bet. It's good to see y'all tonight. Thank you so much for tuning in.
No problem. Good night, ma'am.
Gives me somebody to talk to. I thank you. I'll see y'all.